All right, this is our topic all about cholesterol, and it's a bit of a myth buster. I think once you look at some of the research and stuff that we've put together, you'll see that one, cholesterol is pretty important, and that the standards and guidelines used in Western medicine to identify and treat high cholesterol are somewhat arbitrary, not really supported by science or a lot of scientific study. So we will talk about all that and give you the holistic viewpoint. So what does the clinical research actually tell us about cholesterol? Started out with a thing called the lipid hypothesis, which is a theory that there's a relationship between the amount of saturated fat and cholesterol in the diet and the incidence of coronary heart disease. And one of the first persons that talked about this was Pritikin. However, if you look at his research, he was advocating a lot of things. He was advocating reduced fat, but he was also looking at eliminating white flour, sugar, processed foods, including fresh raw foods and whole grains, including exercise. But when you look at the reports that tout his research as a support for the lipid hypothesis, they only talk about his low-fat component. They don't talk about the other things. So we know that cardiovascular disease incidence rose during the 1900s. It became the number one cause of death in the U.S., and it is still the number one cause of death in the U.S. And during that same time, the consumption of animal fat actually declined. Dietary cholesterol intake has only risen by 1%. But what has changed is that we're consuming a lot more dietary vegetable oils and margarine. That rose about 400%. And we're consuming a lot more sugar and processed foods. So the studies that are actually out there and that are used to prove the lipid hypothesis have actually been unable to establish a definitive relationship. And one of the main studies actually has a direct quote that their results do not establish a definitive relationship between dietary intake of cholesterol and blood cholesterol levels, or a definitive relationship between increased fat intake and heart disease. Also, when they're doing studies on this low-fat theory or hypothesis, they do not differentiate between the types of fat. So we know trans fat's bad, we know hydrogenated fat is bad. They like to say saturated fat is bad and dietary cholesterol is bad. However, they don't differentiate between any of those things in the studies. So we don't know, based on the results of the studies, which of those components or which combination of them is actually causing the results. Also, none of the studies that look at dietary intake of animal fat differentiate between animals that are conventionally farmed versus animals raised in their natural environment. And this is talked about a lot in our clean eating lesson. So if you want to go take a look at that, that dives into a lot more detail of that. So here's a list of the biology and functions of cholesterol. It's an organic molecule, a sterol, a type of fat. It's an essential structural component of our cell membranes. It's the substance that is used by our body to repair blood vessels that have become weak or damaged. Well, that sounds pretty important, doesn't it? It's the precursor for synthesis of important compounds like steroid hormones, bile acids, and vitamin D. Those all sound pretty important. It's required for proper function of serotonin receptors in the brain, which are part of mood, and being part of the structure of the myelin sheath, which is around the nerves, which protects them. It may act as an antioxidant. It can be derived from some foods. Both plant and animal foods may have cholesterol in them. It's also biosynthesized from certain cells, such as our liver and intestines. And intermediates produced from the biosynthesis of cholesterol are used for other functions for the synthesis of other compounds, such as those that carry sugar and protein to the cells, production of COQ, and then compounds that are part of the hemi-A chain, which is iron. All right, so we already said that cholesterol is a lipid molecule. It's a fat. It's minimally soluble in water. So it only dissolves in blood, which is mostly water, at small concentrations. In order to move it around the body, we have to package it with lipoproteins. And that's how it gets transported through the bloodstream. And there are different types of lipoproteins. So we have very low density, or VLDL, low density, or LDL, intermediate density, and high density, or HDL. LDL particles are the primary blood cholesterol carriers that take cholesterol and deposit it into artery walls. And we already said that it goes to repair damage. HDL are the particles that take excess cholesterol back to the liver. And because LDL is deposited in the arteries to repair damage, the presence of it in the arteries is what has caused it to be characterized as bad cholesterol. When in fact, we don't know, just because we have cholesterol in an artery, it was there to repair something. We don't know that it's bad cholesterol just by the presence of it being there. So that's a misconception, that LDL is bad and HDL is good. So we've talked about the lining of our arteries can become damaged, and some of the things that can damage our arteries are high blood pressure, if we smoke, if we have a high level of oxidation in free radicals. Other microorganisms like bacteria and viruses can damage our arteries, or if we have a diet that's high in processed foods with a lot of additives and preservatives. Those are all the things that can damage our arteries. And when they're damaged, the immune system kicks in. Plaque forms at the site of the damage in order to heal the artery lining, forms some scar tissue, and the plaque is definitely made partially from cholesterol. And it's that LDL cholesterol. However, the source of the cholesterol has a lot to do with whether it's going to be healthy or unhealthy. So unhealthy sources of cholesterol, again, processed foods, highly heated foods, they make the plaque less fatty, less elastic, and more hardened. So that scar tissue is less pliable. But healthy sources of cholesterol, the kinds that come from like whole organic foods, are going to make that plaque more pliable and more elastic. So again, we don't know just because of the presence of the cholesterol or the plaque that it's good or bad. It's the type of plaque that makes it good or bad, and the source of that. So plaque in the arteries, known as hardening of the arteries, is a risk factor for cardiovascular or coronary artery disease, especially if that plaque, as we've said, is hardened or less pliable. But there are a lot of other risk factors, including high blood pressure, smoking, diabetes, or a family history of early age heart disease, which is genetics. And we need to be looking at all of these different measures to determine our cardiovascular risk. So our cholesterol levels shouldn't be just the only indicator of whether we're at risk for heart disease. One of the things we now look at is C-reactive protein, which is something that we've started measuring on blood tests. It is a very good measure of inflammation. We need to look at our ratio of HDL to total cholesterol, because a certain ratio is good, a certain ratio is bad. We need to look at the ratio of triglycerides to HDL. We need to look at the ratio of HDL to LDL. We also need to look at homocysteine levels. We have seen in studies that elevated homocysteine levels are definitely correlated with a lot of plaque buildup. So that could be an indicator of something going on there. We also need to look at fasting blood sugar and insulin levels, because diabetes and metabolic syndrome are also high-risk indicators for heart disease. So we want our fasting blood sugar and our fasting insulin to be within acceptable ranges. We also need to look if our iron levels are too high, because those can create oxidative stress and inflammation. And then there are also physical screening techniques. They use ultrasound or imaging, and they can look at different areas like the heart area or the carotid artery to see if there is an excess of buildup based on our age or environment. So again, cholesterol, total cholesterol and LDL is not the only indicator of heart disease. We need to be looking at all of these things to get a complete picture. So what about the trends? In 1983, somebody had cholesterol levels of 260 to 279. Then doctors talked about dietary intervention. And it wasn't until those levels were at 340 that drug therapy was talked about. In 1986, the levels were 240 to 259 for diet intervention. Drug therapy was initiated or talked about at levels starting at 300. And in 1990, the levels were 200 for dietary intervention, and drug therapy wasn't talked about until the levels were 240 to 259. So what happened? In 1990, treatment guidelines and approach changed. They changed significantly. And when physicians were asked, they said that this treatment approach was based on the expert panel report of the National Cholesterol Education Program. And that report specifically recommended cholesterol-lowering treatment for LDL levels 160 or greater in normal adults, or LDL levels of 130 or greater in adults who had a higher risk of heart disease. And one of the statements in this report indicated that physicians who didn't comply with the recommendations would be at risk for like medical malpractice or legal action. So physicians obviously paid attention to this and changed the way that they were treating. Now notice, this doesn't really say anything about total cholesterol, and it doesn't say what the treatment should be. It doesn't say that the treatment would be drug-related or dietary-related. So if we look back at this report, which I did, the studies that are cited by the report to support these recommendations, again, did not demonstrate a conclusive relationship between high cholesterol and death from coronary heart disease. And in the results of the study, it clearly states this statement. So what are the current guidelines? Well, they have come down significantly since those levels in 1990. 200 is still the total cholesterol limit. But if you talk to a doctor now and your cholesterol is at 200 or above 200, they're going to immediately talk to you about drugs. And the current NCEP does classify total cholesterol at 200 or below as desirable, 200 to 239 is borderline, and 240 is high. But they're based arbitrarily on data from a MRFIT study. So this was in 1982, the multiple risk factor intervention trial. And this study looked at almost 13,000 middle-aged men. They were aged from 35 to 57. And these men had other factors. They didn't necessarily have high cholesterol levels, but some of them were smokers. Some of them had high blood pressure, so they had other factors that put them into this study. And the cut point of 240 was established actually pretty arbitrarily. There's a statement in this study that says, quote, the cut point of 240 is believed to be a level at which the risk among people of different backgrounds is sufficiently high to warrant medical care. So we've taken a study of 13,000 middle-aged men who had multiple factors going on, and we've set a standard arbitrarily of cholesterol being high at 240 for everyone, women, people younger than 35, people older than 57. Race wasn't taken into account. Nothing, but we basically set this and extrapolated it to everybody. So that's where the current guidelines came from. One thing, or several things, that these recommended levels do not consider is gender. The study was only on men. We know that cholesterol levels are impacted by hormone levels, and particularly estrogen. So that makes it very likely that normal levels will be different for men and women. We also don't take age into account. We know that cholesterol can act as an antioxidant. It's produced in higher amounts in the elderly, and we've seen that. And it can be to protect against that age-related damage to the arteries. So that might make it normal for elderly people to have higher cholesterol levels and for it to be healthy because it's there to try to heal. Also, they don't take into account genetics. So certain people may be genetically predisposed to have normal cholesterol levels that are higher or lower than others. And then lifestyle. You can have a person who has low cholesterol levels, but if they have an unhealthy diet and they do nothing but sit around all the time, then they're going to be at a higher risk for heart disease, even though they have low cholesterol levels, versus somebody who may have higher than, quote, normal cholesterol levels, but they're very active. They exercise, they eat a healthy diet, they do all the other things that they need to do to manage their health, and that would be healthy. But the guidelines don't really take any of that into account. So when we measure cholesterol, we use the blood, and it's called a lipid panel, and it looks at a couple of different indicators to measure cholesterol levels. It uses medical devices, chemistry analyzers, and they look at the amount of, they look at the color of light emitted when certain chemicals or enzymes are introduced, and that reaction can tell them what type of lipoprotein they're dealing with, basically. And remember that the categories of LDL and HDL actually apply to the lipoproteins that carry the cholesterol. So LDL is not a type of cholesterol. It's a type of lipoprotein that carries cholesterol. Remember? So a typical test can measure the amount of cholesterol carried by each type of lipoprotein as well as triglycerides. That gives you kind of a full picture. Different laboratories will do different things. So there's laboratories that will measure each individual type of lipoprotein. Sometimes laboratories will only measure HDL and triglycerides, and then they'll apply a mathematical formula to calculate or estimate LDL. And those mathematical formulas have definitely been improved and altered over the years. They're still being altered. In 2022, there were some studies talking about a nuclear magnetic resonance lipoprofile test. That's a more accurate method of assessing cardiovascular risk than a lipid panel. And the reasons for that is this imaging can tell exactly the number of particles related to each of the types of lipoprotein. And their contention is that knowing the number of particles for your low density level proteins versus your high density lipoproteins is a more accurate prediction of a risk for heart disease. And the problem with this NMRL is that it takes longer to get test results back. It costs more. And again, 2022 is relatively new, so it hasn't really been adopted. The other thing to note is that within the actual category of LDL, remember you had very low density versus low density, and you have small versus large low density molecules. Well, the small density molecules are actually more prone to damage than the larger low density molecules. So the lipid panel doesn't tell you the differentiation of your small versus large molecules of LDL. So again, it's not really telling you what you need to know about your risk factors. So some of the things that affect our cholesterol levels. Well, certain medical conditions are going to often result in elevated cholesterol levels. If you have any type of thyroid issue, poor thyroid function, if you have metabolic syndrome, which includes prediabetes and type 2 diabetes, if you have liver dysfunction, or if you have pancreas dysfunction, any of those things are going to cause your cholesterol levels to be elevated. And taking a drug to lower the cholesterol isn't addressing the root cause. Inflammation, especially chronic or systemic inflammation, is actually considered to be the primary reason that cholesterol will build up in the arteries. The inflammation it causes the damage to the arteries. Some of the things that will cause chronic inflammation is if our magnesium levels are low, if we have an imbalance of fatty acids, so we don't have enough omega-3 or we have too much omega-6, or a leaky gut, which is also called intestinal permeability. And what that does is it allows undigested food particles and toxins from our gut to leak into our bloodstream, and that can cause our immune system to go, hey, I need to get these things out of here. That causes inflammation. Chronic stress also contributes to increased risk of cardiovascular and coronary artery disease. Stress causes spasm and constriction of the arteries and increased platelet stickiness, and both of those promote clot formation. Stress increases that homocysteine that we talked about. It increases C-reactive protein, and then we talked about that as being a marker, and then it increases fibrinogen, which is a specific type of fiber, or a specific type of protein in our bodies. Stress also suppresses the immune system, so it reduces our resistance to infections. Those bacteria and viruses can cause more damage to cells. And we know stress increases inflammation. So, what about statins? Conventional medicine go-to, if you have any elevation in your cholesterol levels, is to prescribe you with a prescription that's a statin. So what these pharmaceuticals do, they work by blocking an enzyme that actually reduces production of cholesterol by the liver. Common side effects, there's a lot. Muscle aches, diarrhea, could have cold-like symptoms like a runny nose or sneezing or coughing. They can cause heartburn, gas, confusion, joint pain, and urinary tract infections. Serious side effects could include liver dysfunction or failure, muscle weakness and tenderness, kidney damage, or, as with any pharmaceutical, allergic reactions. And statin-associated muscle symptoms are actually fairly common. There's a major reason that people stop taking statin medications. A serious side effect related to muscle side effects is called statin-induced necrotizing autoimmune myopathy or myositis, which is basically when your immune system starts attacking the muscle tissue in your body. And then also rhabdomyolysis, which is a breakdown of skeletal muscle that releases myoglobin into the bloodstream and causes kidney damage. Statins have also been shown to elevate blood sugar levels and induce new onset type 2 diabetes. And what these things do, again, is they artificially lower cholesterol levels. They just block the liver from producing cholesterol, but they don't address the root cause. So again, we need to look at all the factors in our diet, our lifestyle, our genetics that are affecting our risk for cardiovascular disease, instead of focusing just on our cholesterol numbers. So what are some healthy ways to manage cholesterol? Eat whole foods instead of processed foods. Eat clean sources of foods. And again, we have a lesson out there called Clean Eating that goes into that in a lot of detail. You might want to check that out. Eat healthy fats, because we need fats, but we want them to be healthy. So clean animal products, fatty fish, avocados, coconut oil, olives, olive oil, ghee, those are all healthy sources of fats. We want to avoid inflammatory foods because we know that inflammation causes damage to the arteries, increases our risk. So this is like heat processed vegetable oils, hydrogenated oils, fried foods, trans fat, excess sugar, excess alcohol, artificial ingredients, which is what you're going to find in processed foods. We want to maintain healthy blood sugar levels. We want to consume adequate amounts of fiber. The main way that excess cholesterol will get removed from our body is with fiber. So the fiber attracts those excess cholesterol molecules and we eliminate that. So we definitely want to get enough fiber to get rid of what our body considers excess cholesterol. We want to maintain healthy blood pressure levels. We want to manage our stress because we saw that stress causes all sorts of bad effects. We want to get sufficient quality sleep every night. And we want to be moderately active. So move every day. You can do cardio exercises 3 or 4 times a week, but you definitely don't want to have a sedentary lifestyle. Specific nutrients that actually work on cholesterol. So one supplement that has been kind of successful with helping to balance cholesterol levels is niacin. That's vitamin B3. However, niacin supplements have a very common side effect of flushing, so they will cause people to flush and get a heat reaction. So they don't work for a lot of people because of that. Seeds such as hemp seed and chia seed, you can add those into your diet. They have good fats. They tend to help with cholesterol management. Celery or celery juice. One of the things about celery and celery juice is it's natural electrolytes. So electrolytes is a good thing to look at because electrolytes are those minerals like magnesium and calcium and phosphorus. And so probably helping to manage magnesium levels is one of the things that's making celery helpful. Artichokes have a specific type of fiber that's helpful for cholesterol management. Garlic has been studied a lot and used for years and years to help lower cholesterol. Also helps to lower blood sugar and balances our LDL and HDL. And you can get garlic, you can add it to your foods, or you can use the supplements. Alfalfa supplements have actually been studied, and it looks like they block absorption of oxidized LDL, prevent the buildup of plaque. Cinnamon is a vasodilator, so it opens up your blood vessels. It's also hypoglycemic, meaning that it helps to lower your blood sugar levels. So embrace that pumpkin spice. Green tea is high in antioxidants. It's going to help counter that oxidative stress, free radicals. That can help prevent hardening of your arteries and help balance the different types of cholesterol. And then ginger root and turmeric root are both circulatory stimulants. So they help reduce systemic inflammation. So there's a lot of nutrients you can look at. Just add them to your diet to help you manage your cholesterol levels. And I wanted to talk about red yeast rice supplements because they have been studied and actually provide an alternative to statins. And they do help to reduce cholesterol levels. However, they act in the same manner as statins, where they're just blocking enzymes to reduce the production of cholesterol. They're not really looking at root cause again. And they also, because of the way they act, they have some of the same drawbacks and potential side effects. And they also inhibit CoQ10 production, which statins do as well. So if we recap, we've seen that the studies on fat and cholesterol haven't really proven that elevated levels of fat and cholesterol lead to heart disease. We know that it's a necessary molecule for a lot of different cellular functions and structures. We know that the general characterization of LDL as bad is actually misleading and inaccurate. We know that our cardiovascular risk should be assessed using multiple measures, not just our cholesterol levels or our LDL. Statins can have serious side effects, and they don't address root cause. The guidelines and targets are actually arbitrary, and they're not individualized based on our gender, our age, or our genetics. And that healthy nutrition and lifestyle habits are actually the most effective ways to maintain healthy cholesterol levels. So I hope that this has been educational. I hope that it helps you be your own medical advocate when you're dealing with your cholesterol levels and your doctor's treatment approaches. And again, I'm not a licensed medical practitioner. The information here is for education, and you need to make your own decisions about your health. Thanks so much for listening.